Okay, so we are starting with Chapter 14 in Varkarolus, still on Learning Plan 3, and this chapter focuses on depressive disorders. So, depressive disorders, there are several, all share symptoms of sadness, feelings of emptiness, sometimes irritability, somatic or bodily concerns, usually headache, stomach ache, pain issues, some kind of bodily issue, and impairment of their thinking. And these all impact a person's ability to function on a day-to-day basis. So again, these types of disorders are kind of like the invisible disorders. Again, you can't tell by looking at somebody that they have a depressive disorder. Yeah, maybe sometimes somebody might have a sad look on their face, but for the most part, you can't tell that somebody has a depressive disorder just by looking at them. So again, a reason for sometimes stigmatizing people and calling them lazy. They're unable to function the way they should, and they really are making a choice, and that they could change things if they just wanted to. So, we don't do that with medical illnesses for the most part. But we do tend to do this with mental illnesses. So I just have to throw that in every chance I get. Okay, so we really need to think about sometimes delirium and dementia get kind of mixed up with depression, but they really are three very different things. And the thing to remember is delirium and depression are reversible with treatment. So delirium is that sudden onset, usually within hours or days. All of a sudden the person's mental status is completely different. And there could be a lot of different factors. If you work in a nursing home, if you've ever seen a patient have a fever, have fluid and electrolyte imbalances, or have an infection, and you've noticed a sudden change in their mental status, then that probably is delirium. Or could also be in response to starting a new medication, or perhaps even like digitoxicity can cause. There's so many different things that we can think of when we think of delirium. And they fluctuate. Sometimes they look really good, and then all of a sudden they're picking at the air and hallucinating and things like that. But it's reversible. Dementia is not reversible, and you're going to see a slower onset over months. And again, many different types of causes. And again, they have impaired memory and judgment, but not reversible. Depression can look a little bit like both of those. It can look a little like delirium, can look a little bit like depression. Depression can look a little bit like delirium and a little bit like dementia. So the onset might have been gradual with depression. Usually, it's not usually a sudden day and night change in their mood, and it usually exacerbates during periods of stress. So some causes might be something going on in their personal history, having a loss, a crisis, and certain medical conditions can also predispose somebody, and they can all of a sudden become depressed, especially cardiac conditions. They can be forgetful, inattentive, have trouble concentrating. So you might think, is it delirium? Is it dementia? But it is reversible again with treatment. So we have some different classifications, and we're going to go over some things that we would be thinking about and looking for in these different types of disorders. So major depressive disorder is certainly the main depression disorder, and that's the one we see most often diagnosed with patients that are in the hospital. So there are some others. There's something called disruptive mood dysregulation disorder, persistent depressive disorder, which we used to call dysthymia, premenstrual dysphoric disorder, substance medication-induced depressive disorder, and depressive disorder due to another medical condition. So in other words, the medical condition would be really the primary cause of that depression. Case study, Jeff, 19, is brought to the hospital after a suicide attempt. His parents found him in his backyard, wearing his favorite black jeans and black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He has just been admitted to your floor for a 24-hour suicide observation. persistent depressive disorder. So now we're going to think about that case study a little bit and kind of wonder where he falls in this whole realm of different types of disorders. And we're going to talk about persistent depressive disorder. Again, it used to be known as dysthymia. And the thing that's really different about this persistent depressive disorder is that they really have low-level depressive feelings most of the day for the majority of days, and it has to go on for at least 2 years in adults or a year in children and adolescents. So you're probably thinking, wow, 2 years is a really long time to go through depression. And yes, people have difficulties in their life, and they may not be functioning optimally, but they are usually able to function and don't need to be in the hospital. But certainly therapy and possibly some medications would be very helpful for them. But that's a really long time to be suffering. So they have to have at least 2 or more of the following. So these are symptoms that are very similar to what we would see in a major depressive disorder. Either a decreased appetite or overeating, insomnia or hypersomnia, low energy, poor self-esteem, difficulty thinking, and some feelings of hopelessness. Premenstrual dysphoric disorders, the symptoms cluster in that last week prior to the onset of a woman's period, and mood swings, irritability, depression, anxiety, feeling overwhelmed, difficulty concentrating. So all of those can be symptoms that we would see. And these would happen pretty consistently every time the woman has her period. And the symptoms decrease significantly or they disappear with the onset of menstruation. So other depressive disorders, substance-induced, so the person doesn't experience depressive symptoms in the absence or drug or alcohol use or withdrawal. So in other words, it's really, those depressive symptoms are really linked exclusively to drug, alcohol abuse, or withdrawal from those substances. They wouldn't normally have it if they weren't under the influence or withdrawing. Depressive disorder associated with another medical condition. So that can be caused by kidney failure, Parkinson's disease, Alzheimer's disease, and the symptoms that result from medical diagnoses or medications are not considered the same thing as major depressive disorder. So on page 244 in your Vaccarolus, they really give you some very good examples of some different types of medical problems that could manifest as depression. Having a stroke, having a neurologic disease such as Parkinson's, Huntington's disease, Alzheimer's, traumatic brain injuries, arthritis, pain, metabolic conditions. There's so many different things that can possibly cause depressive disorders. But then they would not be considered a major depressive disorder if the primary cause is a medical problem. So again, you would hope that if it's something like, some of those medical, the neurologic conditions can't necessarily be cured, such as like Parkinson's, Huntington's, but perhaps the symptoms can at least be under control. So for major depressive disorder, so this is really the primary depressive disorder that we think about when we think of depression. They have to have at least 5 or more of the following symptoms in at least a 2-week time period. Otherwise, it might not be a major depressive disorder. So when you're gathering your history, you're really looking for consistent symptoms for at least 2 weeks. Many times the symptoms have gone on even more than that because the person might be hesitant to seek some help. So weight loss and appetite changes. Sometimes the weight loss is very significant. It can be a 20-pound, 40-pound weight loss in a very short time period. So we really are assessing for things like that. Appetite changes. Usually it's a decrease in appetite. However, some patients gain weight because they eat more. Sleep disturbances are very common, and many times the sleep issue that is most problematic is that early morning awakening. So the person falls asleep, but then they wake up, very early in the morning and can't get back to sleep. So based on those sleep disturbances then, and even if they didn't have the sleep disturbance that pronounced, just feelings of fatigue, they're tired, they just don't have the energy to get up and go, the energy to do things, the energy to do their own ADLs, to take a shower, to comb their hair. Speaking of comb hair, I'm hoping that you will all look at the, I put something in Blackboard, and it's kind of like an article, and it was about a young girl that had depression, and she didn't, I think, wash or comb her hair for quite a long period of time. I'd have to go back and look at it to see how long it was, but her hair was extremely gnarled, knotty, ratty looking, just really, really in bad shape. And a hairdresser ended up spending hours trying to comb through her snarls and tangles and untangle her hair, give her a nice haircut, and gave her a beautiful new look, which I do hope you just kind of scroll through and take a look at that. But that is really, when you look and see how bad her hair looked, that's what depression does to people. They don't have that energy to even just do their own ADLs. This girl didn't comb her hair for a long period of time. So feelings of worthlessness or guilt. And actually, this girl, I think she went to the hairdresser just hoping she would cut it all off because she just couldn't deal with it. And she didn't even feel worthwhile to have somebody spend that much time with her. So it actually boosted her self-esteem a little bit, because that self-esteem goes hand in hand with feelings of worthlessness or guilt. It's like nobody even should be paying attention to me or helping me or befriending me because I'm not worth it. So this hairdresser took the time and gave her this beautiful new hairstyle, and I'm sure that that boosted her self-esteem and lessened her feelings of worthlessness. The guilt also, I just want to mention too, that most of the time when somebody has a major depressive disorder and they feel guilty, the guilt is not in proportion to anything going on in that person's life. They may say they feel guilty that they were not a good husband, father, worker. They just say that they were terrible. They were a terrible person, and nobody likes them, and that they just feel so guilty about their life and how they've lived their life. But if you talk to their family would say, oh my goodness, no, that's not true at all. They were a great husband. They were a great dad. And so those feelings of guilt are like, where are they coming from? They're kind of coming from that person's low self-esteem. It is many times those guilt feelings are not based in reality. That loss of ability to concentrate. So sometimes people are so depressed that they can't be faced with too many choices. Like even in the hospital, you can't just give them their menu and expect them to fill it out. They might be completely overwhelmed looking at a menu, and they can't concentrate enough to make their choices, or they don't even feel good enough to maybe make some choices for themselves. So you may have to break things down into very small steps for them. So like, for example, if you're going over their breakfast menu, you just do maybe one meal at a time. And then for breakfast, say, do you want the eggs or do you want the oatmeal? Kind of give them two choices, let them choose between two things. And then you can, gradually kind of fill out the rest of the menu. But may need to break down things into smaller, more manageable tasks. They're not going to be able to read anything. They're not going to be able to watch a movie, watch a television show. They just can't concentrate. They have recurrent thoughts of death. So sometimes it ranges from passive thoughts all the way to active thoughts of suicide. So the passive thoughts would be, maybe they hope they just don't wake up in the morning. Maybe they hope that they would come down with a terminal illness. Or they hope that maybe a truck will hit them and they'll just die suddenly. Put them out of their misery. But it's not like they're going to do something active to further that. But so that's passive. But people can have more and more and more thoughts of active suicidal ideation, in which that they would like to commit suicide. Then they might start thinking about plans, and then they might actually be researching on the internet plans, and all the way to starting to practice their plans. So they actually make a noose, they kind of test it out to see if it's strong enough. They kind of go through the motions, and boy, by that point it's getting kind of scary, because then people are at that point then in that whole process of being suicidal and having thoughts of death. They're way at the process of they're going to try something, they're going to take their lives. one other symptom at least usually they have. And of course, having a depressed mood. Sometimes they just say they really are depressed. And then having that loss of interest or pleasure, so anhedonia. That's kind of a strange word, but hedonistic kind of is maybe a word maybe you've heard before, but basically that means like pleasure seeking, and it comes from a Latin root meaning pleasure. So if they have anhedonia, that's a lack of pleasure, so nothing is fun anymore. They can't even think of anything that they would enjoy doing. So just think how difficult that must be for them to experience, that having nothing is bringing them joy, nothing that used to bring them happiness is bringing them happiness anymore. They have also persistent for a minimum 2 weeks to 6 months, chronic lasting more than 2 years. Recurrent episodes are very common. So once you've had a major depressive episode, you are apt to have other ones. So again, we kind of talked when we were thinking about bipolar and trying to keep people on an even keel and keep them stable, keep them from relapsing. We want to think about the same thing for depression. We would like to see people take their medication long enough to really get a good effect, and only go off their medication if their doctor recommends, if their life is really going along very stable. They may or may not need to be on meds the rest of their life, but we certainly want them to stay on their meds for a significant period of time. I would say most of the time it's 6 months to a year at least, just because we want them to reach more of a period of stability. But those recurrent episodes are common. If they've had one episode, they're more likely to have another one. The symptoms do cause distress or impaired function, or really a little bit of both. Sometimes people can't get to work because they're so depressed. They can't get off the couch to be able to perform ADLs or do their housework or do things that they're supposed to be doing in their life. Just not able to do that. So it actually is really quite a cause of disability and loss of work and loss of productivity days in the United States. And it is definitely not attributed to physiological things, so we can't say it's hypothyroidism and therefore they're depressed. Well, if it's hypothyroidism, you can correct that with thyroid medication, and then those type of symptoms that look like depression are going to get better. And it is in the absence of a manic or hypomanic episode, in which case, if they did have any of those manic type behaviors, then for sure they would not be diagnosed with a major depressive disorder. They would be diagnosed with bipolar disorder, either bipolar 1 or bipolar 2. It is the leading cause of disability in the United States. So maybe that's surprising to you. Maybe you thought that cancer, heart disease, lung disease, maybe you thought some of those things, diabetes, maybe you thought that those types of medical issues were the leading cause of disability. But actually, it's very much depression that causes a lot of people to either not be able to function in their daily roles, they miss days from work. So it really is something that we have to start to kind of take seriously. I think your book does a really nice job, too, of talking about children and adolescents and then older adults. So for children, I'm looking at the bottom of page 245, they talk about how depression in children really has been kind of unrecognized for many years, and that actually you can be depressed as an infant. Certainly infants that don't get their needs met, that are being abused or neglected, are going to be depressed. And of course, they are going to be expressing that in a little bit different way. So pretty much not being interested in things around them, not being interested in eating, sucking, feeding, those types of issues. So we have to look at the differences in kids, and then we also have to look at adults, because even though it could be somewhat common for an older adult to have depression, it is not a normal part of aging. So maybe if people think that it's just normal for older people to get depressed, well, it isn't. It is an illness that also needs treatment. So comorbidities. We always have comorbidities when we think of major depressive disorder, and there's many other psychiatric disorders where depression goes hand in hand. So anxiety is probably one of the most common comorbidities. If you have anxiety, you usually have depression. If you have depression, you usually have anxiety, schizophrenia, substance abuse, the eating disorders, personality disorders, so many different psychiatric comorbidities. Again, back to that case study. During the intake, Jeff doesn't speak much, but his parents are able to list the following symptoms that they have observed: weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, and even the online games he usually plays with friends, and just constant sadness. So an audience response question: Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends, and his classes, which he used to like. So this may be best described by the term, I'm hoping that you picked D, anhedonia. Okay, so getting back to causative factors. So we do have biological factors, we have genetic, so certainly these types of illnesses run in families. There's definitely a genetic predisposition. Again, that doesn't mean if you have a family history of depression, you're going to get depressed, but it certainly is going to increase your chances of it. And then, of course, we have biochemical. The brain is really, really a complex organ, and that they have identified neurotransmitters as especially norepinephrine, serotonin. I think those are the ones you're most familiar with, and those are things that really do affect, if those neurotransmitters are out of whack, then we certainly have we see changes like the decreased appetite, low sex drive, poor impulse control, irritability, all of the symptoms that we have. So we do have to look at that. We have to look at stressful life events that can possibly, especially losses and things like that, they can be a significant factor, but usually a stressful event in and of itself isn't necessarily enough to cause a person to go into depression. However, stressful events can cause changes in your neurotransmitters. So it is possible that having an event like that can cause changes in your brain chemistry, which will cause a person to become depressed. Alterations in hormonal regulation. So we kind of talked a little bit already about premenstrual dysphoric disorder. So sometimes when hormones are out of balance, then that can cause symptoms of depression. And more we're looking at inflammatory responses that might be the result of so inflammation can actually be the result of psychological injury as well as physical injury. So it is kind of interesting, and more research really needs to be done in that area. That diathesis stress model, so some genetic predisposition along with stress, certainly is well recognized as something that's a causative factor for depression. Some people seem to have difficult events happen to them and they don't develop a major depressive disorder. So again, there's a lot of variability and individuality, and we always have to think about symptoms again on that continuum. There are some psychological factors that used to have more weight or more impact in how the medical field used to think about these disorders. Thinking about cognitive theory and learned helplessness. So as people, like if people had difficult thoughts, then that would end up changing their mood, and then they would have more symptoms, more depressive-like symptoms, and become more negative, self-depreciatory, negative view of the world, things like that. Okay, that's enough of that. The nursing process. So we're going to always be using our assessment tools. We do have to assess suicide potential. Even if somebody doesn't come right out and say that they're suicidal, if they have the illness depression, we need to be doing a suicide assessment, because that is always the highest priority, is always that type of safety issue when we're thinking about depressive disorders. Even if somebody, again, they're not talking about it, they are at high risk just because they have the illness. So key assessment findings: depressed mood, that anhedonia, anergia, which means lack of energy, anxiety, again, very much a comorbidity, psychomotor agitation or retardation. So in other words, sometimes people have psychomotor agitation, so they're pacing a lot. They're pacing, they're wringing their hands, and it's usually purposeless movement. It's not like they're purposely exercising to feel better. Retardation would be slowed movement, slow behavior, and that would be the person that maybe even slowed thoughts, like you try to engage them in conversation and they kind of sit and stare for a long time before they finally answer you, or they're in bed all day. They're just in bed constantly. And sometimes that happens when you students take care of people that are really depressed. They don't even want to get out of bed in the morning. They don't want to go down to breakfast. They don't want to shower. So many times then, based on our assessment, our interventions are going to follow, and we're going to try to help people with those types of situations. Vegetative signs of depression. Those are bodily signs. So usually that would be like the lack of sleep, lack of appetite, lack of sex drive, constipation, things like that are kind of related to their basic bodily functions. Those are the vegetative signs of depression. And another comorbidity could be chronic pain. I have seen many patients with chronic pain issues that become suicidal if their pain isn't controlled. They just don't know what to do, and they want that pain to end. Either it's physical or psychological or both, and they want that pain to end. So that is a huge comorbidity when we're thinking of depression. So other areas to assess their affect, so the look on their face, their facial expression of their emotions, because that's very telling. Usually somebody's going to have maybe a flat affect. They're not going to have much facial expression, or like a very sad look on their face, anxious, distressed, any of those types of words we can describe. Their thought processes are usually logical. It's not like with bipolar when they're manic and their thoughts are all over the place, or even when we get to the schizophrenia learning plan, some of those thought disorders are just so pronounced that you can't follow people. You don't know really what they're trying to tell you. The thought processes are logical, but they just might be a little bit more slowed. And they just might have more hesitation and just more difficulty concentrating. So sometimes they're not even listening very well to information that's being given to them. They're not hearing it. So it's not that they couldn't remember what you taught them yesterday. It's just that maybe it just didn't sink in at all. So again, their mood, they usually describe it as feeling depressed, down, other feelings. Physical behavior, again, hiding in bed all day, going to groups, socializing with people, or just, not socializing with anybody, wanting to be by themselves constantly. And their, basically their communication as their physical communication, their verbal and their nonverbal. We always have to take a look at those two and kind of put our assessments together. We want to think about their religious beliefs and spirituality. If people have solid religious beliefs, sometimes that could be a protective factor and actually keep that person from wanting to commit suicide, or keep them from making an attempt to commit suicide. Age considerations, again, we have to think about children and adolescents. Kids usually are not necessarily, depending on how old they are, they may not necessarily be able to tell you, yes, I'm depressed, but we have to look at their behavior, their socialization. If they're an adolescent or an older child, are all of a sudden their grades starting to slip? Because that's really one of the first things we want to look at with kids, is how are they doing in school? If their grades are starting to slide, and then all of a sudden they're not socializing with other kids anymore, they're staying at home by themselves, and they are also not doing any of the activities that they used to enjoy. So maybe they're on the track team and they love running, all of a sudden they just quit the track team, or they quit the drama club, something that they really enjoyed, they just quit all of a sudden. So those are really some telling things to look for. Self-assessment, again, we always have to look at ourselves and make sure that we understand that this is an illness, that people are not purposefully being lazy, or again, that they're weak, they're lazy, they're just not as strong as other people, morally corrupt, whatever types of stigma and judgmental things that sometimes society thinks about people that are depressed. So we have to remember it's an illness and that they need help with their symptoms so that they can get better. Feeling what the patient is feeling. Of course, we don't want to ever approach the patient as if we ourselves were depressed, but we certainly don't want to approach the patient with the most cheerful affect ever, because that just makes them actually feel worse. So sometimes you might have to just modify your affect a little bit. Of course, you want to be above their affect, but you just don't want to be way above. You want to give them hope by your coming across in a positive manner, but you just don't want to come across as Susie Sunshine. So, audience response question: what question would be a priority when assessing for symptoms of major depression? Tell me about special powers you believe you have. You look really sad. Have you ever thought of harming yourself? Your family says you never stop. How much sleep do you get? Do you ever find that you don't remember where you've been or what you've done? So I'm hoping that you picked B, so that would be the priority assessment for looking specifically at major depression. So some nursing diagnoses that would apply: risk for suicide, that would always be the highest priority. Hopelessness, if somebody is hopeless, they feel that nobody can help them. Nothing is ever going to change. Nobody can help them. If they're helpless, that's at least a little bit better, because that means that they feel that they can't help themselves, but maybe somebody else can. But if you feel hopeless, you can't help yourself, but neither can anyone else. So that is really a much stronger, predictor, especially of suicide, if they reach that sense of hopelessness. Ineffective coping would be another diagnosis that would be very appropriate. Social isolation, just because they stop socializing and going out and spending time with people. They spend time maybe in a dark room by themselves in bed. So those would be huge nursing diagnoses. Possibly spiritual distress, because sometimes people, they blame God or they're angry at God. They don't understand what's happening, and so that can cause some spiritual distress. And an absolutely self-care deficit, because these people do not get into the shower, do not brush their teeth, wash their face. They may barely be eating meals and drinking fluids appropriately. So we have to really do all those things for them, or make sure that they're doing them, really encourage them. Hand them the wet washcloth, hand them the toothbrush with the toothpaste already on it. So we have to really think about using sometimes very strong directive encouragement. So we're looking at our outcomes then, our goals for patients, and we always want to try to think about something called the recovery model, which focuses on the patient's strengths. Again, everybody's an individual person. Two people with depression are not going to be the exact same. Treatment goals, we have to mutually develop those with the patients, because we can't tell them where they're supposed to be at. We really want the patient to kind of come up with a goal of where they would like to be. And again, so these are really individual, based on the patient's personal needs and values. We really can't put on them our own values and what we think they should be accomplishing. So plan, and that's geared towards the patient's phase of depression. So whether they're in the deep, dark throes of depression, if they're starting to get a little bit better, looking at their particular symptoms, and again, the patient's personal goals. 3 different phases: the acute, the continuation, and the maintenance phase. So I'm looking at the bottom of page 253 in Varkarolus, where they talk about the 3 phases. So that acute phase is that first 6 to 12 weeks. Usually the person is in the hospital, especially if they are suicidal. We would definitely want them in the hospital for treatment of their major depressive disorder, and that we want to reduce those symptoms and restore them back to where they were able to function, especially if they were, if they were working, or even if they weren't working outside the home, that they were able to function in whatever capacity they used to function at. The continuation phase, 4 to 9 months, is really directed at preventing relapse. So again, we want the person to stay on their medications, not just stop taking them because they feel better. Education, and do specific depression-specific psychotherapy. So to work with them on feelings, how they feel about themselves, their goals, managing their life, managing stress a little bit differently. And then that maintenance phase is a year or more, and that's usually trying to prevent further episodes of depression, because again, you're more at risk if you've had one episode, and medication might be phased out, after a year, but for some people it may not be. Depends on if it's their maybe second or third major depressive episode, then we would probably want them to continue on medication for a little bit longer. But we always should try to think about these as we're gearing our interventions towards maintaining the patient as a functioning, contributing member of society once they have recovered. So counseling and communication is an important part of our nursing role. We can help people, we're not doing therapy counseling like an advanced practice nurse or a psychotherapist, a physician. We're not in that type of a role, but counseling certainly can mean that we are trying to help that person to continue to think about ways in which that they can grow and continue to have a healthy life. So we use our therapeutic communication skills for that. Health teaching and health promotion, promoting self-care activities, and of course teamwork and safety, because if somebody is suicidal acutely, we want the whole treatment team to be involved with that and everybody watching out for that person to make sure that they stay safe. So psychopharmacological interventions, there definitely are a variety of medications to choose from. So, we might not be the ones choosing the medication if we are, unless you're an advanced practice nurse, but the doctor is really looking at what symptoms the patient has, and then the side effect profile. Because say a male with depression maybe is a younger male and maybe 20s, 30s, and they really want to have children. And perhaps they're married and they're really looking to have children. And I know that I've seen this situation before in the hospital. So they are not going to choose an antidepressant that is going to have sexual side effects, and that person is not going to, if they really want children, that's a goal in their life, they are not going to continue to take that medication, and nobody can blame them for that. The other thing to look at too is the weight gain. So if somebody has difficulty with maintaining their weight anyways, giving them an antidepressant that might tremendously increase their weight gain, they're not, again, people are not going to be compliant with taking a medication if they're gaining a lot of weight. Ease of administration, history of past response, safety and medical considerations. I know sometimes in the hospital, if they're treating multiple family members for depression, they will also kind of look at which medications that other family members are responding to, because then they genetically are more likely to respond to medications that their family members are on. And we always have to look at safety and medical considerations. There are some antidepressants that are cardiotoxic. So if they have heart disease, you do not want them on certain types of medications. So lots of different things to think about when the doctor is prescribing. And we as nurses can also take a look at some of those. And if we know that somebody has an issue, a medical issue, and the medication is either contraindicated or whatever, then we can talk to the physician about that, and hopefully they would be able to make a change. And actually, the patient is able to refuse. So if the patient was they were concerned about taking the medication with their medical condition, you certainly can let patients know that it is their right to refuse the medication, that they should talk to their doctor about their concerns. So again, we can't, we're not going to bash the doctor and say, oh, why did he order that? Or why did she order that? That was, not the best choice for you. We're not going to say things like that, but we can say, hey, if you got concerns, talk to your doctor about it. And you certainly can refuse to take your medication in the meantime until you've talked to your doctor and had your questions answered. So we have SSRIs, and those are really the first line therapy that doctors will choose. Pretty much of a rare risk of serotonin syndrome. So again, lots of different things to take into consideration. Serotonin norepinephrine reuptake inhibitors, so SNRIs, they might be tolerated even a little bit better. So those medications might be chosen. Tricyclic antidepressants, you definitely have some anticholinergic adverse reactions, and some of those reactions can be kind of serious, like causing somebody to have urinary retention to the point where they can't urinate at all. They may have to go to the emergency room to get cathed because they can't urinate. So there are some other anticholinergic side effects that, really aren't that bad, like the dry mouth and things like that. But they could also be dizzy and have orthostatic hypotension, which is going to cause them to fall. So, putting them in a little bit of danger. So lots of different things to look at when we're thinking about, we as nurses, assessing for some of these side effects. So, and monoamine oxidase inhibitors, honestly, we used to give them quite a bit back in the old days to people, usually to people that did not respond to the tricyclics, because years ago we didn't have the SSRIs or the SNRIs, so we didn't have such a variety of medications. So if somebody had trouble with the tricyclic antidepressants, they would put them on an MAO inhibitor, but the MAO inhibitors are really serious. You can have some very serious side effects with those. It's they can be effective for unconventional depression that maybe doesn't fit into another category or people aren't responding. But honestly, because they have to follow so many dietary restrictions and they can't be on lots of other medications interact with MAO inhibitors, so they can be kind of dangerous to take. You really have to have somebody who's very, very compliant and really wants to take these medications, because they're helping them to get better. But actually, if somebody has a personality disorder, or if they have a major depressive disorder and they start to feel suicidal, it'd probably be pretty easy for them to just, go overboard on some of the foods that they're not supposed to have and have a hypertensive crisis. So that means that their blood pressure could go very dangerously high, or take some medications too that are contraindicated with MAOIs, and they could cause a reaction and think that they're going to have a stroke and die. So, maybe yes, maybe no, but honestly, if they don't die, they certainly can cause some grave physical damage to themselves. So MAO inhibitors really have to be monitored very, very carefully. So other treatments for depression, ECT. Again, I don't see that used as much. We don't do it in Sheboygan anymore. It is offered throughout the United States. Here in Wisconsin, I know that they do ECT in like Mequon, Milwaukee, probably Green Bay area. Bigger Madison, I'm sure, offers it. In bigger cities, you will find ECT. The physicians have to become certified in giving this treatment. So it's I'm misspeaking. Electroconvulsive therapy. So you are basically inducing a seizure in someone when you give them ECT treatment. It is definitely much more humane than it used to be when it was first discovered, but it is kind of interesting that the first people that got ECT, they made this into an actual therapeutic treatment for depression, because people observed that when patients who had a seizure disorder had a seizure and they woke up from their seizure, their mood was better. So somebody kind of put two and two together and said, well, then let's induce a seizure in people who have a depressive disorder and see if that doesn't affect their mood. And actually, it does affect their mood to a very positive benefit. And I've seen people over many years, when I worked in Rochester, New York, many people got ECT treatments and just did so much better because of the treatment. And again, if you can't tolerate the antidepressants for some reason, they're just not working for you, ECT really can be a very viable alternative. But some other things that they've come up with in the recent years has been the transcranial magnetic stimulation, vagus nerve stimulation, deep brain stimulation. So all of those things have quite a bit of hope for people, again, that have depression that doesn't respond to anything else. Light therapy, St. John's wort, and exercise, those can be adjuncts to treatment, but you're not going to use St. John's wort especially as a first line. That's never going to be your first line of defense. Maybe people buy it over the counter and think, oh, I'm feeling a little down, I'll just take some St. John's wort and I'll be all better. But actually, I've read some articles recently that really talk about that it's not very effective. There might even be some side effects for people. So we should really caution people that talk about wanting to use other types of non-pharmacological interventions or like herbals, because those herbals can have side effects for people. They're not right for everyone. Light therapy can be very helpful for people that have seasonal depression. So like this time of year, we're hopefully it's February already, so hopefully we're going to be heading into spring eventually, and we'll be turning the clocks back and we'll get more sunlight again. So the people that have seasonal depression are definitely going to be feeling better anyways, whether they had light therapy or not. They're going to feel better once we get more daylight. Or if people that have a seasonal affective disorder, seasonal depression, if they move like to California, Arizona, any place that gets more sunshine than Wisconsin, they may actually just kind of get better on their own. But sometimes people might need a little bit of medication through that period of time where it's more dark, and some light therapy. So light therapy actually can be done relatively inexpensively in a person's own home. You can order a light box online, and if you have a doctor's prescription for it, your insurance might even cover some of that cost. I don't believe that they're all that expensive for home use, and you just sit under that light for half an hour, first thing in the morning when you first wake up, and usually don't give it to yourself too late in the day, because then it might keep you up at night. But it actually is considered very effective. They have a beautiful light box on 1K in the clean utility room, so I will definitely point that out to you when you go through clinical and we do a tour of the unit. So exercise. Well, exercise can help anything. Exercise helps our mood. It helps our anxiety level. It absolutely is a wonderful thing to do. However, in and of itself, it is not a cure for either depression or anxiety. Again, can be used as an adjunct. And I do think that it's just, part of healthy living. It really does help if somebody with depressive or anxiety disorders, if they do engage in regular exercise, it really can help them overall with helping to keep their mood on an even keel and to help their anxiety level. So I do believe in exercise, but I just don't think it's enough to if somebody's on a really deep major depressive episode, exercise in and of itself is not going to be enough to pull them out of that episode. But lots of friends and family members, I think, try to say like the last 3 are things that maybe their family members should do. It's like, oh, just exercise and you'll feel better. Take some St. John's wort, do a little light therapy. It may or may not be enough to really pull them out of their episodes if they're actually in a real major depressive episodes. So again, ECT is very, very helpful, and actually it can also be used if people are psychotic and if their psychosis just isn't responding to anything else. So especially we want to think about ECT if somebody is malnourished, completely exhausted, dehydrated due to a very lengthy depression, so it's going to get them out of it relatively quickly. It is considered safer than meds. Which is kind of interesting because you do go under general anesthesia for this. It's a very short-acting anesthesia, and they also give you a muscle relaxant, so they need to be bagged for a short period of time. So it is a little bit risky, but I've seen this over and over again, and I have definitely seen people respond very, very positively. It can be helpful if people are delusional, so they have false ideas along with their depression, and again, failure of previous medication trials, or if somebody has a catatonic episode along with their schizophrenia. And we'll talk about schizophrenia and catatonia a little bit more when we get to that learning plan. So the transcranial magnetic stimulation is non-invasive. So again, research is being done in some of these things, and people are getting these treatments usually in bigger cities. Hopefully there will come a day in the near future where many of these treatments will come to the smaller communities, Sheboygan, Manitowoc, places that aren't huge cities. So the presence of metal is the only contraindication. So kind of interesting. And there are a couple of adverse reactions that we have to think about. But, when you think about the medication, the reaction, the possible side effects with medication, and especially serotonin syndrome, this might be actually a little bit better alternative for some people. So, yeah, and vagus nerve stimulation, kind of same thing, it actually decreases seizures and improves mood. So it was originally used to treat epilepsy, especially people that medication doesn't help them, and they maybe have seizures so often that they aren't able to function very well. So they may have some side effects with that too, some neck pain, voice alteration, cough, paresthesia, dyspnea, which tends to decrease with time. So nothing is without risk. It's just a matter of finding an individual treatment that's best for that patient. Now, deep brain stimulation, a little different because they have surgically implanted electrodes in the brain, and so it's a little bit more invasive. The electrodes are placed directly into the brain. However, again, if you are suffering from depression and you can't function at all, you can't work, you feel suicidal, something like this might be an alternative that is better than not having any treatment at all, and especially if you can't tolerate medications. So, and again, light therapy, first line for that seasonal affective disorder, and kind of we're thinking about melatonin and that whole impact. So, and the way that we are in the darkness, and so areas that have seasonal affective disorder, if you looked at a map of the United States, definitely the northernmost states are the ones that are going to have the most difficulty with seasonal affective disorder, and the southern states are not going to have, they're going to have very little instance of seasonal affective disorder. So yeah, they might have a little bit of headache, jitteriness, and usually if they do the light therapy too late in the day, they may have trouble sleeping. Okay, well, here it says useful in mild to moderate depression, but honestly, I have read articles that say that there really isn't that much research done, and that sometimes it's just downright not effective or even harmful, because again, we do have to look at our herbals and possible side effects to those. So, yep, I really kind of already talked about it. Exercise, definitely very, very helpful, but again, it's not going to be enough usually to bring somebody out of a major depressive episode. Advanced practice interventions, therapy, lots of different types of therapy, group therapy, individual therapy, all those things. So the future of treatment, Healthy People 2020 objectives, and just think it's 2019, so 2020 is next year. Just kind of wondering where we're at in terms of meeting any of these objectives. Are we any closer to meeting any of these? It'll be interesting to find out. But anyways, so the future is we're trying to improve screening for children and adolescents in a variety of healthcare and community settings. So if you've got kids especially in high school, they may be doing some screening for depression and suicidal ideation in high school. So just kind of giving kids different types of questionnaires to fill out. In doctors' offices, more and more, they're doing depression screening and doing suicide screening, which is actually a good thing, because sometimes people just aren't necessarily going to get an appointment quick enough to see a mental health professional. So kind of everybody is taking a little bit more of a leadership role in screening. So we want to reduce the incidence of depression in children, adolescents, and adults, increasing mental health treatment to adults and children and adolescents in primary care, and increasing the number of patients with depression, both children and adults, who are going to receive treatment, because many people with depression don't get any treatment, or they get maybe substandard treatment because they really don't seek treatment from a health professional. Maybe they're going to friends or family members, or kind of looking online, kind of self-medicating or whatever, and they're not really getting effective treatment. So again, suicide, part of the suicide, oh boy, nursing process, not the suicide process. I guess my eyes went directly to suicidal ideation. So we're evaluating. We want to make sure that when we evaluate as part of the nursing process, that we're seeing either the absence of suicidal ideation, or at least that person is able to contract for safety. So that's a huge thing we're going to focus on. Their intake, we want their intake to be improved, not only of food, but fluids also. We want to see them gain some weight back if they've lost 40 pounds recently, have more stable sleep patterns, personal hygiene and grooming improved, their self-esteem, they actually feel better about themselves, and they're interacting with people more. Their friends, family members, maybe they're getting visitors more, maybe they didn't want visitors at first, or even just socializing more with other patients on the inpatient unit. Those would all be some positive things that we're looking for. So the national goals in Healthy People 2020. So again, kind of a quality improvement thing. Think of CUSIN again. Increasing the percentage of individuals with major depressive disorder who receive treatment to at least up to 75%. So that would really be huge. Increasing the number of physicians' offices who routinely screen for depression. And I am definitely seeing this more and more. And as everyone kind of jumps on the bandwagon, we should definitely see more screening, more people identified who need treatment, and people getting that treatment that they need. And the Center of Quality Assessment and Improvement in Mental Health, they have links to reliable outcome measures. So again, it's actually a very scientific process that we're doing in mental health. Chapter 25, Suicide and Non-Suicidal Self-Injury. I had a couple of blank slides there. Okay. So the definition of suicide is the intentional act of killing oneself by any means. And of course, there are many means that people use. Some means are more lethal and some means are less lethal. But sometimes even those less lethal means can still lead to death. So when we're assessing, we really do have to take a look at that. Suicidal ideation means the thinking, the thought process about killing oneself. So it could be, again, all the way from passive suicidal ideation all the way to active suicidal ideation. You can have suicidal ideation without a plan, suicidal ideation with a plan. And if the plan is really well thought out and rehearsed and well, researched, then we're really getting to the point where that person is more than likely going to act on their thoughts. So a completed suicide means that the suicide, I don't like the word successfully. I think that's a bad word. That really came right from your book, and that's a bad way to put it. Just that the suicide resulted in death. Non-suicidal self-injury, so that would be like self-harm. That would be self-injury directed to the surface of a body to induce relief from a negative feeling, cognitive state, or to achieve a positive mood state. So people that self-harm do it to feel better. They do it to decrease their anxiety rather quickly, and it's a coping mechanism. Of course, it's not a good coping mechanism, not a positive one, but it is something that people use to kind of feel better. But the thought process is not that they're going to die, that they're going to commit suicide, but more of they're going to seek relief from their inner turmoil. So suicide is the 10th leading cause of deaths in the United States, the second leading cause of death for ages 10 to 34, fourth leading cause of death for ages 35 to 54, eighth leading cause of death age 55 to 64. So it is a huge 10th leading cause of death overall in the United States. So that's pretty alarming because suicide should be a preventable form of death. Suicide rates among active duty service members has surpassed civilian rates. So we really have to look at our military and then our veterans when they're done with their military service. We really need to focus a lot more on providing them with services. So that is just absolutely unacceptable, that those rates are so high. So suicide rates among veterans is increasing more rapidly than that of the general population. So again, really need to focus our efforts on that. Case study. Gino, 14, identifies as transgender, saying, I have known since I was real little that I was meant to be a girl. I'm a girl on the inside and I always have been. As soon as I'm of age, I'm going to get surgery for gender reassignment. I've been saving my money for as long as I can remember. In the meantime, I asked my friends to call me Gina instead of Gino. I grew up with these same kids, so with my friends, it's really no big deal. So that, just thinking before I read the rest of that is another issue that can cause people to have suicidal ideation, because there is so much misunderstanding, and they are on the receiving end of a lot of stigma and prejudice, so they really can feel very low self-esteem. They feel lost. They may not have a very big peer group of other people that support them. So anyways, this year, however, things have changed a bit for Gina. Growing up in a small neighborhood school in the city, she's now entered a new, larger school. She doesn't always have classes with her friends, and she's beginning to get pushed around in the halls. Recently, Gina, who dresses and grooms herself as a girl, tried to use the girls' bathroom, which was allowed at her small private school, and a teacher followed her in and shooed her back out, calling her disgusting. So think about the bullying and the verbal, physical abuse that sometimes people endure. That will be certainly a stimulus for them to feel suicidal. So other risk factors for suicide, especially for suicide, having any type of psychiatric disorder. So any diagnosable psychiatric condition, whether it be bipolar, depression, schizophrenia, a personality disorder, an eating disorder. Those would probably be the very most common ones. So if they have a diagnosable disorder, that is a huge, huge risk factor. Another really big one is alcohol or substance use disorders. So people sometimes that are under the influence of a substance or of alcohol, they may behave in a way that's suicidal, even though perhaps if they were sober, they would never feel that way or never think that way. Taken care of patients in the hospital that have said they got really, really drunk, and then apparently while they were drunk, they tried to commit suicide, and then when they sobered up and they were in the hospital, they couldn't believe that people told them, yes, you actually were in the bathroom, you had swallowed a bunch of pills, or you were starting to make a noose and tie it around your neck, and they couldn't even believe that they were doing something like that, because once sober, they didn't feel suicidal. So sometimes just alcohol or substance abuse in and of itself can cause people to act in a way that is suicidal or self-harming. But certainly if you have an underlying depression or anxiety or schizophrenia disorder, and you take a little bit of alcohol or a substance, your inhibitions are lowered, and therefore you may act on something under the influence that maybe you wouldn't have the guts to do if you were not under the influence. So that alcohol or substance can really, whatever drug it is, I'm thinking probably more of an illegal drug than anything else, would certainly cause that person to lose their inhibitions, and now all of a sudden they have the nerve, the ability to follow through. Male gender. So that is actually a huge risk factor. And right now, as far as recent statistics, middle-aged males are the highest group that is a risk factor. So being a middle-aged man is a huge risk factor for suicide. And then again, increasing age. So we can't think about older people as, oh no, that person would never commit suicide. I've seen people in their 70s, 80s, and 90s that have been suicidal. So that is definitely a risk factor. Race, 85% to 90% Caucasian. So that is a risk factor. Religion, again, or if somebody has really strong religious beliefs that are against suicide, that might protect them. But other types of religious beliefs might, not protect them, or they may not feel supported by their particular religious denomination or belief. So that might be a very difficult thing for them to deal with. Marriage, usually if somebody is married, that should be a protective factor. So if somebody is not married, if they're divorced, if they're having marital difficulties or separated, or single, never married, those could be a little bit more of a risk. They're more at risk than somebody who is happily married. Professional people are more at risk than blue-collar workers. There's more stress if you have a professional role, more expectations, and you may have to work harder and harder and harder for the same salary. You have people that might be upset with you, angry with you, pushing you to do more, and a blue-collar worker is not necessarily going to be experiencing those that same level of stress. So we always have to look at our profession as a risk factor. And then you think about some professions like people that are police officers, firefighters, that deal with nurses, physicians, that deal with death and trauma on a regular basis, and that certainly can affect people over time. And if your physical health is good, it's certainly going to protect you from suicide. But if your physical health is on the decline, that can be a very strong predictor that you're going to try to commit suicide. So definitely there's a familial tendency. So if a person has a family member that has committed suicide, they are absolutely at risk for committing suicide themselves. So it's genetic, and it has to do with also with those lower serotonin levels that are something that is a familial tendency. So psychosocial factors, we don't really need to, again, get really deep into Freud and Menninger and things like that, Aaron Beck. But I do think that the hopelessness is a very significant factor. So you don't need to memorize Freud, Menninger, and Aaron Beck, but just hopelessness is huge. Because again, if people get to that point where they don't think anybody can help them, then that will be a strong predictor of suicide. And again, that diathesis stress model, combination of suicidal fantasies, a significant loss, that genetic predisposition. There are such things as copycat suicide. So sometimes people, especially like maybe kids in high school, somebody committed suicide and now somebody else is going to be doing the same thing. The other type of event that can precipitate a copycat suicide is that if it's a public figure, an idol, a singer, a rock star, something like that. So, or again, a peer in their community. Adolescents are very high risk because they tend to have immature brain function and they can be a little bit more impulsive. And actually try to do the same thing by kind of emulating and admiring that person. They may end up trying to commit suicide in the same way that somebody they look up to and admire would commit suicide. So again, we've really got to think of our LGBT youth and bullying, online bullying, name calling, verbal harassment, physical harassment. Very, very huge issue. It's really an issue, I think, overall in general in our society and among youth. But if you think about people that are more likely to be bullied, this group definitely would be. So in sexual minority youths are more likely to report suicidal ideation. So again, you have to look at about all the different factors about do they have a support system? Are they being ostracized by their family, by their peers? Do they have a good support group? If the answer is no, that can make things very, very difficult for them and drive them to suicide. I think I'm going to stop this recording. It's over an hour now, and I will start another recording soon.